Right, let's go. Good evening, everybody, and thank you for joining us for the next in our series of webinars from OCL Vision. For those of you that haven't met me, my name is Purvi Thompson. I am one of the optometrists who works with OCL. To all of you that are joining us for the very first time, a big hello and welcome. And for all the regulars, a huge hello again. I would again like to thank you for all the positive feedback that I receive, and ideas that you have for future webinars are always greatly received. It was fantastic to meet a lot of you for the first time at our in-house event in Elstree, but for now, we're back to Zoom. So as you all know, things have changed and I will no longer be uploading points directly to the GOC. Instead, I will send you out CPD certificates and you now have to make sure you update them to your own GOC. So please do ensure that when you register for webinars, you do have your correct name and GOC number as it is on the register. So for today's event, there is one interactive CPD point for optometrists and dispensing opticians. As always, this webinar is recorded and will be available to view along with our other webinars on our YouTube channel, OCL Vision. This lecture will run for about 45 minutes with questions at the end. So if you have any questions, please pop them into the Q&A box throughout the lecture and we'll get through as many as we can at the end. So tonight, I am very excited to announce today's speaker, who is our newest consultant at OCL Vision, Masara Laginaf. Masara is an ophthalmic surgeon at OCL Vision. She specialises in cornea, including grafts, complex cataracts using premium IOLs, and also refractive surgery. Her NHS base is at Luton and Dunstable Hospital. Masara, I'm excited for this one. If you want to share your screens, over to you.
Thank you very much for that introduction. So hopefully you can now see my screen. I'll just launch the presentation. Okay, so tonight I'm going to talk about cataract surgery in the context of corneal disease, a roadmap to success. And I think this is a really important topic to cover. It's something I see very commonly in my clinics day to day. And I think it's something that's very useful for optometrists to be more aware of. So, aims of the webinar. So I'd like to summarize what I mean by the roadmap to success. I'd like to discuss the corneal conditions in the setting of cataract surgery, highlight what kind of management and optimization we can implement for these patients to optimize their outcomes prior to cataract surgery, any surgical planning or techniques that we need to implement, how to set patient expectations appropriately, and how to ultimately improve patient outcomes and satisfaction. So when I say roadmap to success, we always start with patient expectations. We have to do a thorough history and examination and assessment to make the appropriate diagnosis. We then need to think about how we're going to optimize these patients prior to surgery. We want to then take our measurements for the surgery to ensure that we have the most accurate refractive outcomes. At this point, we will counsel the patients to ensure that they have realistic expectations of what we can achieve, make any appropriate surgical planning, whether that's planning for specific IOL types or calculation of specific IOL formulas, for example. What kind of techniques we will use during the cataract surgery to ensure the optimal success, any postoperative management required, and then ultimately we want to reach to that patient satisfaction at the end. So the corneal conditions I'm going to cover today are quite varied, from things like dry eye, which we see very commonly, all the way across to our irregular astigmatic conditions such as nodular degeneration and pterygium, and even touching on herpetic keratitis and prior corneal surgeries. So dry eye I'd like to touch on first. This is an incredibly common condition that we see day to day, both in optometric practice and in ophthalmic clinics. So it's very, very common in the cataract population. One study found that there was dry eye in up to 80% of cataract patients. Another study found that there was a 63% staining rate in patients and a 70% rate of tear breakup time being reduced. We have both asymptomatic and symptomatic disease. And asymptomatic disease we know can convert to symptomatic disease after cataract surgery. So it's very important to optimize these patients preoperatively to get the best possible outcomes. We know that surgery can trigger dry eye in patients and can trigger those symptoms, and I've definitely seen it in my own practice. And so it's very important to identify that preoperatively. It can also impact significantly on the reliability of our preoperative measurements, in particular our optical biometry, and that can then impact on our refractive outcomes. When we're using IOLs like toric IOLs, we also want to assess for astigmatism, and we do this with biometry and corneal tomography most commonly. And so we need to optimize our measurements in order to optimize our astigmatic outcomes as well. We know that the threshold for using multifocal IOLs is pretty high, and if patients have untreated dry eye or significant dry eye, this may preclude them from being a candidate for these IOLs. And it will also impact on the performance of these IOLs post-operatively. So this is the TFOS JUICE 2 report. This is a flow chart showing the assessment and diagnosis of dry eye. And what was interesting is if you look at the asymptomatic category, if they have signs of ocular surface disease, TFOS recommend that we treat these patients prior to any surgery, because we know that preventative management is very important. So what is it about cataract surgery specifically that exacerbates dry eye? Well, there's a number of factors at play here. Essentially, we are inducing some form of ocular surface trauma, both to the corneal epithelium and to the conjunctival epithelium and goblet cells. So during the surgery, the eye is exposed and it repeatedly dries throughout the surgery. So every maybe 5 to 10 seconds, the cornea will dry and will need to be irrigated. Sometimes we will coat the cornea in some kind of HPMC type solution, which is like a clear gel, and that can help to reduce the amount of drying and irrigation that occurs during the surgery. And I will use that for patients that have very dry eye. We know that the eye drops used around the time of preparing the patient for surgery can be quite toxic. So the povidone iodine that we use, the topical anesthetics preoperatively, and also the other thing with anesthetics that's quite interesting is if you have a patient waiting to come in for the surgery, they may have an anesthetic placed about 10 to 15 minutes before they come through. And in that time, because of the anesthetic, their blink rate might be reduced as well. So that can have quite a big impact on the ocular surface by the time they come through to surgery. Post-operatively as well, we use things like non-steroidals, preservatives in our drops, and these can all exacerbate the ocular surface after the surgery. Phototoxicity, again, not a lot of evidence for this. It's more of an issue with the retina, but there is some evidence to suggest phototoxicity can play a role in ocular surface trauma, particularly if the surgery is prolonged. Surgical trauma itself, so things like placing a speculum, using, for example, femtosecond laser suction ring, if you're doing femtosecond laser assisted cataract surgery, and just general manipulation of the eye during the surgery. So this can all exacerbate dry eye, but also you've got your incisional nerve damage as well. So making those main wound incisions, so the larger the incision, the more impact that can potentially have on the nerves, and placing multiple side ports, and also doing incisional surgery such as astigmatic keratotomies or limbal relaxing incisions at the same time of cataract surgery will cause some damage to the nerves and ultimately may exacerbate dry eye. So I know a lot of you will already be very familiar with this type of flow chart or this type of table outlining the dry eye management. And really your management will be determined by the severity of the dry eye and the type of dry eye, whether it's more meibomian gland dysfunction, evaporative, or aqueous deficient, or possibly even a mixture of both. And the time taken between treatment and potentially reassessing the patient varies depending on the severity of their dry eye. So I tend to prescribe preservative-free lubricants, sometimes a short course of topical steroid, and sometimes for more severe cases, topical cyclosporin like Icurvis. The most important thing is to treat and reassess, and also remeasure. So you may have some biometry from the initial appointment, and what I would normally do is treat them and bring them back and redo those measurements to see if there's any difference, and also look at the corneal tomography, topography, and clinical signs, and also symptomatically whether the patient is improved, and then we will decide together whether to proceed. So that's dry eye in a nutshell. Astigmatism, technically not a corneal disease or condition, but when we remove the cataract, we are left with corneal astigmatism. The lenticular astigmatism is essentially removed by removing the lens. So what we're left with is some degree of corneal astigmatism. Most eyes will have a small amount, but what's interesting is we do, I would say about 40 to 45% of the eyes that I see have at least one diopter of astigmatism. And an interesting study that was done in 2018, looking at the global burden of astigmatism, found that there was around one diopter of astigmatism in 47% of cataract eyes. And that's quite a huge refractive burden on patients. So do we correct astigmatism in all patients? No. In the NHS, it's very much a postcode lottery. And in the NHS, there's a much higher threshold for placing a toric lens. In the private sector or in the refractive practice, we do have a much lower threshold for placing a toric lens, and I specifically do as well. So how do we assess astigmatism prior to refractive surgery, or prior to cataract surgery, sorry? So we will always perform a refraction, optical biometry and keratometry, or corneal topography and tomography. And the reason for this is I like to compare the astigmatism in my biometry to another parameter, whether that's corneal topography or tomography. If a patient is suspected of having irregular astigmatism, you may pick that up with just retinoscopy, where you may see a scissoring reflex in the eye. Contact lens over refraction is very useful. So if you place a hard or rigid gas permeable contact lens on the eye and then refract over that, if you find that the vision comes up considerably, that could suggest that the patient has irregular astigmatism, because what the hard lens does is it neutralizes some degree of that irregularity to then bring up the vision and allow you to refract them to a better visual acuity. So that can be very useful. Something we use in refractive surgery particularly is OCT epithelial thickness maps. And you can see the image on the top left. This is actually a patient with keratoconus. And what we see with these epithelial thickness maps is the corneal epithelium can change depending on what's going on underneath in the anterior stroma. And so if you have a patient with a cone, let me just show you here, you can have thickening of the epithelium around the base of the cone. And what typically occurs over the peak or apex of the cone is this characteristic thinning. So you can pick up these subtle changes prior to considering someone for refractive surgery, just with an epithelial thickness map. And so this can give us clues as to whether there's any underlying irregularity in the cornea. Anterior segment OCT is also very important. You can look at the cornea in cross-section and determine at what level the corneal disease is at. And we can also do wavefront aberrometry looking at higher order aberrations in the cornea. And that picture is Purvi refracting me a few months ago. So for regular astigmatism, what do we do? So when we're performing cataract surgery, there's a number of things we can do. One thing I like to do, if possible, is to place an on-axis incision. So if somebody has, say, 1 diopter with the rule astigmatism, so they're steep at 90, if you place an incision at 90, you could potentially reduce that astigmatism by about 0.5 diopters. So without using a toric IOL, you've already reduced their astigmatism to some degree. And the reason that happens is when you make an incision in that area, you're essentially flattening the cornea. Other procedures, other incisional procedures include limbal relaxing incisions, which are made, as the name suggests, by the limbus. And these can be made with a special blade that we use for LRIs, and we can determine the length based on the amount of astigmatism we want to correct and nomograms that we have that we can use for that. Astigmatic keratotomies are a little bit more effective. They're closer to the center of the cornea, so they're placed closer to the optical zone, and so they're a bit more powerful in what they can do. So for astigmatic keratotomies, you can correct up to usually around 3 diopters of astigmatism. But for most surgeons, if they were looking at correcting that, they would opt for a toric lens. I would generally use AKs for somebody with around 1.5 diopters of astigmatism. And the reason for that is incisions in the cornea have been shown to be slightly less reliable because you never quite know how an individual patient is going to heal. And so they may have a good result initially, but 6 months to a year down the line, that the effect may have somewhat worn off because of healing. And so toric IOLs are generally the preferred option for regular astigmatism at the time of cataract surgery. So how do we mark toric IOLs? There's a number of ways you can do this. Manual marking is very effective, and you can do this either by marking them at the slit lamp before the surgery. So you can either mark the axis at which you want to place the lens, or you can mark them at 0 and 180, and then place a Mendes gauge on the eye when they're lying down to then determine where you're going to place the lens. You can also use devices like RoboMarker, which gives you that nice mark you can see in the top top right-hand corner of your screen. And you also have digital marking systems, which we have at OCL Vision. And the picture on the right is an image of a Callisto, which is a Zeiss digital marking system that is inbuilt into our microscope. And you see it in one eyepiece at the time of IOL implantation. So it's a little bit like having a bionic eye, and it really is very effective. The reason we mark them sitting up to begin with is because patients tend to exocyclotort when they lie down. And so if you wait to mark them when they're lying down, the results in some patients could be off by almost 10 to 15 degrees. So it's very important to mark them sitting up. So irregular astigmatism is a huge thing to consider prior to cataract surgery, because this could impact on their refractive and visual outcome. So first of all, you have to identify what the cause is. Is it just some dry eye? Is it something like epithelial basement membrane dystrophy or Salzmann degeneration? Could be pterygium, corneal ectasia, some form of corneal degeneration, scarring, or even prior corneal surgery, such as a previous penetrating keratoplasty or corneal transplant. You want to ascertain whether this is something you can treat, because that will ultimately determine what the prognosis is for the patient and whether you may need to approach cataract surgery in a more stepwise sequence. So I always say to stage the treatment, so address the cornea first where possible, and then consider cataract surgery at a later date. Repeat your measurements prior to doing the cataract surgery to ensure that you are getting the most accurate K readings, and consider your IOL choice. So for significant irregular astigmatism, you'll probably want to use a monofocal IOL. If there's a large degree of regular astigmatism with some irregularity superimposed, you could still use a toric IOL, and these patients can still have very good outcomes, particularly, for example, patients with mild keratoconus. For patients who have a lot of irregular astigmatism, you could also consider these new pinhole IOLs. And the most common popular option at the moment is the IC8 by AcuFocus. And this is essentially a pinhole IOL. So it's got that pinhole type effect, and it increases the depth of focus. I'd like to talk specifically about Salzmann nodular degeneration now. So this is a fairly rare condition. It's slowly progressive, and it causes these gray, white, or bluish nodules measuring anywhere from around 1 to 3 millimeters. And they tend to occur in the just anterior to Bowman's layer. And they're usually bilateral, and they tend to present in patients over the age of 50 years old. They're much more common in females, but I have seen them in men, and I have seen them in younger patients as well, particularly East Asian populations. Now, the etiology is contentious. I think it's primarily due to, in my experience, posterior blepharitis, so having significant lid margin disease. And the literature says that it can occur in patients with kind of chronic ocular surface or chronic inflammatory disease of the ocular surface. It can be both limbal and mid-peripheral. If it's very limbal, if it's very peripheral, it may not really pose a problem when you're performing cataract surgeries. It may not be inducing any significant irregular astigmatism. But if it's in the mid-periphery, it's pretty close to the optical zone. It's pretty close to that central visual axis. And so it may need to be treated prior to any cataract surgery. You have both asymptomatic and symptomatic nodules. So some patients describe a foreign body sensation. I have seen some patients with significant pain, and you can also have epithelial defects overlying these nodules. So it's very important to stain them with fluorescein to check for that prior to any cataract surgery or prior to commencing any treatment, because they may need antibiotic cover, lubricants, and optimization of their ocular surface in the first instance. As I said, they tend to have blepharitis or posterior lid margin disease, and they tend to have an overexpression of MMP2, which can cause destruction of the underlying Bowman's layer. So how do we treat this? First of all, you need to consider both conservative and surgical methods, whether they have irregular astigmatism, so this can be detected on corneal topography or tomography. You always need to manage their blepharitis and ocular surface. That's really important. You can perform a superficial keratectomy for these patients, so you can actually peel the nodules off, which is one of the most satisfying surgeries, and then apply mitomycin C, which helps to reduce the recurrence rate of these lesions. Some surgeons will also use excimer laser to ablate these lesions. They might peel them first of all and then use the laser to smooth the corneal surface. And that can work really nicely for these fairly central or mid-peripheral lesions. Rarely, in only very severe cases, would you consider keratoplasty or amniotic membrane grafting. I would normally recommend that you allow 3 months of corneal remodeling. That's the typical time frame that we recommend after corneal surgeries before remeasuring and performing cataract surgery. So I just wanted to show you this video because it's just wanted to highlight the importance of peeling rather than cutting into these nodules, because you can see that there's a natural plane by which the nodule wants to come away. And it's rather satisfying to watch, but once you've got an edge, it's very easy to peel these nodules away. And you can see there, it's coming away rather nicely, all in one piece. And once that's done, I would usually use mitomycin C, wash the eye copiously, and you could also place a bandage contact lens to aid with healing post-operatively. Next, I'd like to move on to pterygium, which again can induce a lot of irregular astigmatism, just like those nodules we discussed. So most of you will be very familiar with this picture. A pterygium is essentially a wing-shaped fibrovascular growth, usually originates in the limbal conjunctiva and extends into the cornea. Typically caused by chronic UV exposure, and the most important thing when considering cataract surgery is whether to remove the pterygium before. They can induce quite a large amount of corneal astigmatism, and I've actually been surprised and caught out myself in the past by how very flat, atrophic looking pterygium can still have a huge impact on the amount of astigmatism. They also can have kind of ocular surface discomfort, foreign body sensation. They may have Delin or irregular tear film, and so that needs to be optimized at the same time as considering any further surgery. So there is an argument for doing simultaneous surgery in possibly in developing countries where patients are coming and they may only be able to attend for one operation. They may consider doing kind of simultaneous operation, but generally speaking, the recommended way of approaching this is to do a staged conjunctival autograft and pterygium excision at the same time, and then the cataract surgery at a later date. And the reason for this is we want to improve the reliability of our refractive outcomes. And if you have flattening of the cornea due to the pterygium, you're going to get abnormal K readings and you're going to pick the wrong IOL power. So it's important to do the pterygium excision and conjunctival autograft in the first instance, treat the ocular surface and remeasure the patient, usually again around 3 months after the pterygium excision. For cataract surgery, I generally recommend to avoid making any incisions at the site of the pterygium. Now, I tend to operate temporally, so for me, that's not so much of an issue. And if you have a double-headed pterygium, so one that's nasal and temporal, I would normally recommend making your incision superiorly. And the reason for this is there tends to be some scarring, there tends to be some limbal stem cell deficiency, possibly in that region as well. So I just like to avoid making any incisions and having any problems with healing of those incisions post-operatively. So this is an image of a patient with pterygium, and you can see that I've taken a graft. This is just underneath the upper eyelid, and so this is me sitting from the top. I've taken a conjunctival autograft. I've peeled away the pterygium, very much like the Salzmann nodule peels off. You can also peel these off. And I've placed a graft with tissue glue. And what this will do is this will take in the coming weeks. And after about 4 to 8 weeks, that will look very nice. And that will look almost indistinguishable from the original conjunctiva. This will heal very nicely because it's underneath the upper eyelid, which naturally creates an environment whereby the conjunctiva will heal. This is a really nice pre and post-op pterygium surgery image. You can see it's obviously very small, that scan, but there's about 5 diopters induction of corneal flattening just with that pterygium, and that is resolved upon removal. So it's important to consider removing them for that reason and to stage your remeasurements and your cataract surgery at a later date. I'm going to move on now to corneal dystrophy. So again, epithelial basal membrane dystrophy is another cause of potential irregular astigmatism. It's the most common form of corneal dystrophy with a prevalence of around 2.5%. We often debate whether this is truly a dystrophy or a degeneration because the majority of cases are actually rarely hereditary. And so the majority of patients with this condition, they actually have it as a degenerative condition. Histology tends to show a thickening of the basement membrane with deposition of fibrillary protein, and it tends to occur due to poor basal epithelial cell adhesion to the basal lamina. You get an absence of normal hemidesmosomes and anchoring fibrils, and you get a continued secretion and intraepithelial extension of the basement membrane, which is this region here. You can see me pointing to this. And these are what cause those characteristic map-like appearances. You get a breakdown of hemidesmosomes and degeneration and sequestration of epithelial cells, which cause these microcysts and these dots within the cornea. And the deposition of fibrillar material is what gives you this typical fingerprint pattern over here. So treatment and management of EBMD is targeted towards 4 key problems. Number 1, the ocular surface. That needs to be optimized prior to cataract surgery. If they have recurrent corneal erosion syndrome and it's very acute, I would withhold any cataract surgery at that point because you really need to try and get that under control prior to any intraocular surgery. You want to ascertain whether the EBMD is causing any significant corneal opacity because that will impact on your visual outcomes. And you want to also assess whether this is inducing any irregular astigmatism, which you can often detect just on corneal tomography. So in terms of the conservative management for ocular surface, as per your dry eye management, that's what you would do. If the patient has recurrent corneal erosion syndrome, as I said, in the acute setting, for those of you who came to the L3 talk, you will have seen this slide before, intensive lubrication, ointment at night, plus or minus cycloplegia in the painful acute stage, topical antibiotic when they have an epithelial defect, sodium chloride ointment at night can be very helpful, usually for the first few months at least. And for severe cases, or if you have a large epithelial defect, you may want to consider a bandaged contact lens and consider the addition of tetracycline antibiotics orally. So for treatment of recurrent corneal erosion syndrome and irregular astigmatism and corneal opacity, you might want to consider some form of surgical intervention. And the most common form of surgical intervention is a superficial keratectomy. You can either debride the epithelium manually, you can use alcohol to delaminate the epithelium. If they have recurrent corneal erosion, you may want to do anterior stromal puncture, where we puncture into Bowman's to encourage adherence of the epithelium when it regrows. And you can also consider the option of excimer laser PTK. So if we debride and remove the epithelium and give everything a polish, let it reheal, you'll actually usually have quite a nice ocular surface, quite a nice, smooth, even surface, and then that will allow you to redo your biometry measurements and then reliably choose your IOL. So this is the kind of approach that I would take if it was visually significant. Moving on now to our favorite corneal dystrophy, Fuchs endothelial dystrophy. This is an autosomal dominant disorder, but tends to be sporadic in the majority of cases. It tends to be more common in females, and it's due to a primary endothelial cell loss due to dysfunction of the endothelial cells, and you get a failure of the NAK plus ATPase pump, which allows the accumulation of fluid and corneal edema. There is a higher incidence of primary open-angle glaucoma in this population, so it's important to assess that prior to considering any surgery. And they tend to present with a gradual decline in vision, often worse in the mornings, and it may be exacerbated or arise after cataract surgery. And the reason for this is we naturally lose endothelial cells at the time of cataract surgery. Stage 1, as you know, you tend to have corneal guttata appearing, and you may see these peripheral Hassel-Henle bodies, which look like guttata, and they essentially are, but they're normal for some people. And so I don't tend to worry too much about these patients. But if they have confluent guttata or significant widespread guttata, I'd be thinking more about Fuchs endothelial dystrophy. They sometimes have this beaten metal appearance where they have a combination of guttata and pigment on the endothelium. And if you see this, then you would probably want to refer this patient into a corneal surgeon for consideration of cataract surgery. Once you get onto stage 2, you might start to see descemet membrane folds and stromal edema, and they may even develop epithelial bully, which can be painful. Stage 3 is really severe when they develop recurrent corneal erosion. They can develop a subepithelial vascular pannus and stromal haze. So what do we need to think about when we're performing cataract surgery in these patients? We generally like to perform preoperative endothelial cell count if we have access to this technology, and corneal pachymetry, which is fairly straightforward to do. Generally speaking, if they have an endothelial cell count of less than 1,000, if they're heading to some 6 to 650 microns in corneal thickness, if they have stromal edema, if they are complaining of worsening vision in the morning, if they're getting any kind of microcystic edema in the epithelium, you might want to think about doing a combined cataract extraction and DMEC or DSEC corneal transplant, because these patients are very likely to decompensate after cataract surgery. So you have to assess them very thoroughly preoperatively to make that judgment. And sometimes for a specialist, sometimes it's difficult to make that call, especially if you're not a corneal specialist. And so sometimes in these more moderate cases, I would recommend referral onto a corneal specialist. The first thing we would do when we're doing surgery on these types of patients is we would always use a protective dispersive viscoelastic, so something like Viscoat or Endocoat. And this is a type of viscoelastic that protects the inside layer of the cornea during the surgery. And we call this a soft shell technique. We like to try and minimize the phaco time, so the amount of time that we're doing phacoemulsification inside the eye. And we also want to try and reduce the ultrasound power that we're using. So instead of doing a standard divide and conquer technique where we're doing a lot of phacoing, a lot of turning, more phacoing, cracking, we might just do a stop and chop type procedure where we do minimal phaco, more cracking with our second instrument or our hook rather than using more phaco power for that. As I said, I would consider referring kind of all moderate cases onto a corneal specialist to consider the option of combined or staged cataract and corneal transplant. Thinking about the refractive target, if we're placing a DSEC in the eye, we need to leave the patient a little bit more myopic when we're choosing our IOL. So if we're planning a staged IOL, phaco IOL, and then DSEC, we'd probably leave them more myopic. If we're doing a DMEC, there is an argument that you should leave them around -0.5 diopters because they are likely to get that slight shift once you've done a DMEC. I tend to aim a little bit minus. I probably don't go as minus as 0.5 if I'm doing a combined phaco DMEC, and I've had very good outcomes with that approach. The main thing really is to counsel them effectively, because there is a risk of decompensation. It might not be straight after the surgery, it could be years later. So it's important to explain to them that cataract surgery will cause some loss of endothelial cells, and for them to understand and appreciate that before the surgery. So DMEC surgery is, I'm just going to show you, for those of you who weren't at Elstree, I'm just going to show you what it involves. So the first thing we do is we have to prepare the graft ourselves. In some countries, they have them preloaded and pre-prepped. And so what we do is we score the endothelium. We then check that the edge is free. So we move all around the edge to ensure that it's free. We will then carefully peel the graft. So you can see being very delicate here. The concern at this point is that the graft can tear. Now I've peeled it back, I'm punching the graft. We then turn it over, and essentially at this point we are marking the graft. And we usually use a little F mark. And the reason we do this is so that we know which way round the graft is. Once we've done that, we turn the graft back around and we then peel the rest of the graft, and then we punch the graft. You can see it's very delicate and the graft can tear at any point, so you have to be very careful with preparation. And once that's punched, we then place the graft inside the eye. So I'm just going to show you what that looks like. So this was a patient, it was actually quite challenging, this operation, because the patient had a very deep anterior chamber. So unfolding this graft was very difficult. And you can see I was trying to press on the graft to open it up, but unfortunately the graft would not open. So you sometimes have to vary your technique depending on the shape and the individual eye. So with this patient, I pressed very firmly on the main wound. And what that allowed me to do was shallow the AC enough to open the graft up. Everything is done externally, so I'm tapping on the outside of the eye to open up the graft. You can see that's opening up very nicely, but I'm having to place quite a lot of pressure on that main wound. And then what we do is we place SF6 gas inside the eye to pin the graft in place. So that's how the graft is positioned, and hopefully when the patient comes back, the graft is attached and the cornea is starting to clear. So that's DMEC surgery in a nutshell. And that's just a transplant of the inner layer cells, so the endothelium and the desmase membrane, which is 10 to 15 microns thin and thinner than a human hair, should I say. So I want to move on to talk about band keratopathy. Sorry, I think my screen went a little bit glitchy for the last 5 minutes, so hopefully you can still hear and see me. So band keratopathy I wanted to cover because it's something we do see relatively commonly, and sometimes it can be very mild with just this kind of 3 and 9 o'clock type pattern. And sometimes it can coalesce and form more of a prominent band right across the cornea. And obviously this will impact on the vision and the refractive outcomes of the surgery. It's essentially a progressive subepithelial deposition of calcium phosphate salts. And you can see here it can be very mild, moderate, or it can be very severe and painful, as can be seen on the picture on the right-hand side. So the ocular causes, the most common cause is your anterior segment inflammation, so chronic anterior uveitis, chronic keratitis, corneal edema, or silicone oil in the AC can all predispose patients to band keratopathy. And we sometimes see this appearance in bicycle eyes. And systemic conditions to be aware of are things like hypercalcemia, hyperphosphatemia, chronic renal failure. So it's important in these patients, if the reason or the cause is unclear and it's bilateral, it's definitely worthwhile sending the patient for routine blood tests. So what is the treatment? It really depends on how severe it is, where it is. If it's at 3 and 9 o'clock, patient's completely asymptomatic, they don't have any foreign body sensation, no reduced vision from the band keratopathy, and no pain, then you really don't need to be treating this prior to cataract surgery. But you may wish to make your incisions outside of this region, so possibly superior, for example, if it's temporal and nasal. If it's visually significant or it's inducing a lot of astigmatism, you can do something called EDTA chelation and superficial keratectomy. So this is when we place EDTA solution, which essentially chelates the calcium, helps to clear the calcium away and remove the clouding from the center of the cornea. And the way that we do this is we remove the epithelium first over this region. We then soak the eye in EDTA solution, and this can take a very long time, sometimes even up to 30 or 40 minutes of repeatedly soaking and wiping the cornea to clear the calcium phosphate away. And this is a very nice pre and post-operative image. You can see here you have a large band of band keratopathy, which is cleared very nicely after a 30 to 40 minute operation. With this, we'd normally place a bandage contact lens on the eye afterwards. You can also do excimer laser ablation as well, particularly if it's centrally involving, and also to act as a smoothing type treatment as well. Again, with this type of procedure, I would recommend letting it heal, letting the cornea remodel, which takes around 3 months, and then remeasuring the eye, so repeating your biometry before doing any IOL selection. This is a really interesting case I saw at Luton. We had a 71-year-old male. He had an unaided left visual acuity of counting fingers, pinholing to 6/15. Interestingly, he had bilateral, pretty severe band keratopathy, and he had excimer laser 20 years ago to both eyes, and then had EDTA chelation done again 10 years later. Sorry, 10 years prior to this appointment. He was an RGP wearer, and he was unhappy with his vision. He had about 1 to 2 plus of nuclear sclerotic cataract in the left eye. and wanted it sorting out. So he was quite interesting in that he had a central round clear zone, and either side of that at 3 and 9 o'clock, he had quite dense band keratopathy. And he had a huge amount of corneal astigmatism, and actually 7.8 diopters of corneal astigmatism. He had a little bit more on the biometry, so I decided to go more on the pentacam than the biometry. And the plan for him was to treat him with cataract extraction and a custom Rayner Ray 1 toric IOL. The reason being that although he has some irregularity, most of his astigmatism, as you can see from the corneal tomography, is actually pretty regular. And he had an amazing outcome. At 4 months postoperatively, he was 6/6 vision in that eye. And so it's interesting with these patients that you can use a toric lens for something that you may think is fairly irregular and still have a very good outcome. Next, I'm going to move on to herpetic keratitis. So we're really jumping around here, but I hope that I'm giving you a flavor of everything. So when we see patients who have a history of herpes simplex or herpes zoster eye disease or keratitis, there's a few things we need to think about. The main thing is to ensure that the eye is quiet, that they don't have any active disease, and ideally they should be quiescent for at least 6 months prior to the cataract surgery. And now, a lot of patients with herpes simplex who get recurrent disease will be on acyclovir prophylaxis, and that tends to be 400 milligrams twice daily. And this dosing and this regimen comes from the HEADS 2 trial, which was performed a couple of decades ago. And what this found is that if you take this prophylaxis, it can reduce the rate of recurrence by 1/3. And so when patients are on this medication, I often increase it in the first month post-cataract surgery. And if they're not on the medication, I will normally give them some tablets post-operatively. If they're on BD, I sometimes increase it to TDS, but I don't tend to give them a full treatment dose for a month just because it's quite a lot of medication to take. And a full treatment dose is 400 milligrams 5 times daily. For somebody with a history of herpes zoster, it's a little bit more complex. There's not a huge amount of evidence of prophylactic use long-term, but I may consider giving them oral acyclovir 800 milligrams BD, for example, in the first month post-op. It really depends on how severe the disease is and how many recurrences they've had in the past, but that's something to think about always. They may have some form of corneal opacity or scarring or vascularization, and sometimes that can impact on the surgical view, and it can also impact on their visual outcomes. So I have to counsel them appropriately and tell them what they're likely to expect post-operatively. You also need to warn them that there is a risk of flare and recurrence when they have cataract surgery. And we never quite know who's going to flare up, but it's important to either cover them with acyclovir, watch them very closely post-operatively, and make sure that they understand that further recurrences can occur in the future. And this could impact on their cornea, their level of scarring, and eventually their visual outcome. We know that they're at increased risk of inflammation, uveitis, and they may even be more likely to develop CMO post-operatively. Some of our patients with HSK or herpes zoster keratitis, they may be relatively neurotrophic, or they might have reduced corneal sensation. And so I would always advise to use topical NSAIDs such as Acular or Nevenac, fairly sparingly and with caution, because what you don't want to do is induce any kind of corneal melting. It's very important in these patients too to make sure their corneal surface is optimized as much as possible. Moving on to ectasia, this is a huge topic in itself, but I'm just going to touch on a few points because I think we're running a little bit low on time. The majority of patients presenting for cataract surgery will be in their 50s. Keratoconus tends to stabilize around the age of 40, 45. So you should be dealing with a fairly stable cornea at this point. But patients with pellucid, more in middle-age years, they may still have some form of progression, and so they may need cross-linking prior to consideration of cataract surgery. So you really need to ascertain the stability and the severity of the ectasia. Always optimize the ocular surface. They tend to be dry, they tend to have allergy, particularly keratoconics. So it's important to optimize that preoperatively. For irregular astigmatism, they may already be an RGP wearer and they may be very happy to continue wearing that after cataract surgery. So with these patients, we tend to opt to leave them a bit minus so that they're easier to fit for their contact lenses. They may benefit from PTK with cross-linking to regularize their cornea prior to any surgery. They may be a candidate for intracorneal ring segments prior to surgery to optimize their anterior corneal curvature and to flatten the cone. So there's things we can do prior to cataract surgery if they're eligible. The majority of patients will have a monofocal or spheric IOL, and they may be suitable for a toric IOL because a lot of their astigmatism will be regular. There will be some degree of irregularity, but it really depends on how severe the keratoconus is. If it's mild, then they could do very well with a toric IOL. So these are just some of the things we can do for keratoconics to regularize the cornea. So intracorneal ring segments, Kera rings are very nice for regularizing the cornea. We can also consider this pinhole IOL in these patients as well, especially those with a lot of irregular astigmatism. This is a bit of a minefield, so I won't go into too much detail into this topic, but IOL calculations in keratoconus can be more difficult. And the reason for this is that you just don't have a normal cornea. And the relationships between the anterior and the posterior cornea are abnormal. There is a lack of consistency along the corneal curvature. The effective lens position that we use in our IOL formulas is very difficult to predict with keratoconics because they tend to have increased corneal curvature, longer eyes with greater axial length and greater AC depth. They also have tear film irregularities, making their biometric measurements more inconsistent. And so we can't really apply standard formulas in the normal way for calculating our IOLs. There's been lots of studies done. SRKT seems to be the most reliable of the formulas, but most patients risk a hyperopic outcome if we use these standard formulas. So what we tend to do is aim to leave these patients more myopic, particularly in our moderate to severe keratoconic patients. So just something to think about. If they've had prior corneal refractive surgery, in particular radial keratotomies, there's a few things we need to think about. They tend to drift into hyperopia over time. So this was a treatment that was given to patients usually in the 1980s for myopia. And so they have these cuts through the cornea up to about 90% depth. So they have these very steep, deep cuts. And they may have 4 radial keratotomies, they may have 16. So that really does pose some challenges when we're planning cataract surgery. And they can have irregular astigmatism due to these cuts. They can also have very unstable refraction, and they can have diurnal variation whereby the refraction actually changes throughout the day. Patients who've had LASIK and PRK are also a challenge. They tend to be very demanding because they are refractive surgery patients, so they want to be spectacle independent. And if they've had myopic LASIK, for example, if you choose a typical IOL based on typical formulas, they could end up being hyperopic postoperatively. So you've got to make adjustments based on what type of treatment they've had in the past. So you do have to counsel them that there's an increased risk of refractive surprise and talk to them about what you might do if that happens, whether that's an IOL exchange, doing a piggyback IOL where you put another IOL on top to correct any residual refractive error, or doing further refractive laser if that's possible. Luckily, we have the ASCRS calculator, which is designed for patients who've had previous refractive laser. So we have an option of prior myopic LASIK or PRK, prior hyperopic LASIK, prior RKs. And we can enter information if we have it about how their eyes were pre and post-operatively, or we can just use the biometry data that we have to hand. And that can give us much more accurate outcomes. In terms of our surgical planning and technique, for radial keratotomies particularly, we like to avoid those incisions. So we always make our incision between the RK cuts. If there's too many cuts, we can also do a scleral tunnel. The other thing to say is that when we're irrigating inside the eye, that buildup of pressure inside the eye can cause these cuts to open or split open. And so we have to bring the bottle height down, lower the pressure inside the eye, and make those little adjustments to ensure that we don't have any complications. We also have to check at the end of the surgery that there's been no leak from any of these wounds, because it doesn't take a lot for these wounds to split open. And sometimes in those cases, we would have to suture the wounds back up if they were to split. So there's a few things that we have to consider when we're operating on these patients. The final thing I will touch on is corneal transplant. The main thing to say with these patients is they're at higher risk of endothelial failure from any intraocular surgery. So if you're performing cataract surgery on these patients, you want to make sure that you avoid the graft-host junction with your incision, so make it fairly limbal or posterior, and you want to use a soft shell technique to protect the endothelium, and you want to counsel the patients that there is a small risk of graft failure and endothelial failure following this type of surgery. So take-home messages are always to take a detailed history and corneal examination, refraction, Consider whether it's the cataract or the cornea that's causing the problem, or both. Optimize them in the community, so that mainly means optimizing the ocular surface. Consider referring them directly to a corneal or anterior segment surgeon when required. Optimize the ocular surface always. Treat them and remeasure. Try to allow 3 months for corneal remodeling before considering cataract surgery after any corneal intervention. And to always counsel them appropriately and set patient expectations. So I think we've achieved everything we set out to achieve. And thank you very much for listening, and I'm happy to take any questions that you might have.
Maz, that was absolutely fantastic. Thank you so much. Would you mind just unsharing your screen for me, please? And we've got quite a few questions to get through, so I'm going to make a start as you're doing that. Yeah. So a couple of questions on the pinhole IOL, the IC8 that you mentioned. One of the questions was, does it affect the visual field? And the second question was, can they be inserted bilaterally, or do you only do it monocularly in the non-dominant eye, for example?
Yeah, so they tend to be implanted. You can put them in both eyes, but most people opt to put them in the non-dominant eye. So, for example, a study that was done on radial keratotomy patients, they found it was more effective to implant it in the non-dominant eye and put a monofocal in the dominant eye, because you are going to get some impact on your visual quality with these lenses, and there can be a bit of a dimness around the peripheral vision. So I think it's better to opt to put it in a non-dominant eye, or to at least avoid putting them in both eyes simultaneously. In terms of visual fields, you can still do a standard kind of Humphreys visual field test, and it doesn't impact massively on those results. So you can place them in glaucoma patients. Great, thank you.
We had a couple of questions, the same one about the Salzmann nodule dystrophy that you mentioned, or degeneration. Can Salzmann nodule degeneration be managed or treated even without cataracts? And how about if the patient is asymptomatic, would you still do treatment then?
So yes, so I have treated patients who are pseudophakic and phakic but don't have cataract with Salzmann nodules. So if their visual quality is poor, if they're complaining of reduced vision and they have nodules involving that mid-periphery, then they're likely to benefit from having them peeled. But you have to counsel them that it's going to take them a while to improve. So it can take months for them to appreciate any improvement in the vision. And that's because of the slow healing process, the remodeling of the cornea. They have a poor ocular surface anyway. So you can treat them without cataracts, basically. We treat it on its own all the time. And what was the other question, Purvi?
And can you just have surgery anyway, regardless of whether they have cataracts or not? Would you still remove the Salzmann?
Yeah, I answered that one. I think I didn't answer the first question, sorry.
Let me go back and find that. Thanks, Masara. Let's have a little look. We'll come back to that one when I find one. Let me ask you the next one, if that's okay. What is the prevalence of recurring pterygium if you use a conjunctival graft? Is there a better alternative?
Conjunctival autograft is the best option. The recurrence, so I used to quote 1 in 100, but some studies now are suggesting it's 1 in 1,000. So it's really effective. It depends on the population, I would say, and it depends on the pterygium. If it's Afro-Caribbean population, they're more likely to recur. And if they've had a recurrence and you treat that, they're more likely to recur again. So with those patients, I would opt to use mitomycin C. So if I'm doing a recurrence, I'll use mitomycin C to reduce that rate of recurrence. So it is really very low with conjunctival autograft. You can use amniotic membrane as well, but it's not as effective. And those are usually only reserved for patients who don't have the conjunctiva to spare for the surgery.
Masara, is there a difference in the way you treat these patients in an NHS versus a private? For example, if you had a patient who had a pterygium, but it wasn't impacting the vision or coming onto the cornea that much, would you leave it in the NHS? And versus private, would you think, well, that's potentially going to come and impact, let's do that surgery first and get a better outcome for the cataract surgery? Is there a difference?
Ultimately, it depends on the patient. So it depends on what the patient wants. So for example, I had a patient turn up to my direct access kind of cataract pathway on the day of surgery for cataract surgery in the NHS. And he actually had quite a big difference in astigmatism between the two eyes. And I knew it was because of the pterygium, which actually looked quite small and quite atrophic, but it was inducing about 2 diopters. And I did offer them the opportunity to have it staged, but they just wanted to have the cataract done because by that point it was bothering them so much. So generally speaking, I'll be guided by the patient. If he was adamant he wanted it removed, I would have removed it. So it depends on the patient and what their expectations are and what their refractive desires are. If they're very keen to be spectacle independent, then we should try and remove it for them. The other thing to mention is it depends on what IOL you want to use. So if someone comes to you in the private sector wanting to use some form of premium IOL, for example, then you really have to optimize their ocular surface and their refractive outcomes as much as possible.
Great. A couple of questions on dry eye disease, actually. One, can you use multifocals in patients with dry eye disease? And secondly, why don't we always recommend preservative-free eye drops?
So preservative-free eye drops, generally, if you're going to use drops long term, they need to be preservative-free because the preservatives in the majority of drops, such as hypermellows, usually BAC type preservatives, they have been shown clinically to cause low-grade ocular surface inflammation, which over time can actually exacerbate the dry eye, the vicious inflammatory dry eye cycle. So it's important if you're going to be using them for any great length of time, so more than a few months, really you want to be looking at giving them preservative-free. The other thing is if someone's a contact lens wearer, you really need to avoid preservatives in the drops. The second question was about, sorry, Purvi, remind me.
Multifocals in dry eye disease patients.
Yes, you can. It depends on the severity and the symptoms. So if somebody has mild dry eye, a bit of lid margin disease, you can treat it, optimize them, remeasure them, re-refract them, because it's very important to have accurate measurements, because that's what you're going to be basing your IOL calculations on and your IOL selection. And you know, with multifocal IOLs, in order for them to perform as good as possible, you need to nail your refractive targets. So if they have mild dry eye, I will treat it, reassess, and they could potentially be a candidate. And they usually do quite well. But for moderate to severe dry eye, patients that are symptomatic, you know, it may impact on the performance of the IOL and they may not be suitable.
Just in practice, when we've been at work, actually, we've noticed those that have dry eye post cataract surgery, lens surgery, have multifocals. If you treat, and they're a little bit unhappy, if you treat the dry eye, you know, after 4 to 6 weeks, if you've treated it, they come back ecstatic that they can see distant, intermediate, near, and no issues whatsoever. So it's interesting what impact dry eye does have. So another good question. How early do you send a patient for cataract surgery if they've got Fuchs?
So yeah, this is a really good question. It's a tough one because you don't want to do the cataract before it needs to be done, because you know that you could exacerbate the Fuchs, but you don't want to leave the cataract too long that it's much more dense and it's going to take more energy to remove, because that could potentially lead them to lose more cells. So it's about finding that sweet spot, isn't it? What I usually advise is base it on what the patient says. So base it on the patient's symptoms, and if they're complaining of a decline in vision, then I would refer them in. If they're asymptomatic, they're not complaining, they're managing, they're within driving standards, then you don't really need to refer them in. But once they start complaining, that's when you need to get an opinion, and then we'll make that judgment call. I
have an optometrist that said actually in their trust, there's huge delays in the combined corneal cataract surgery. So in those kind of trusts, what do they do? Do they do the cataract surgery? Do they do the DMEC? Do they wait?
So it depends on how bad the Fuchs is, because sometimes we'll do a combined operation on people whose Fuchs might be impacting their vision a little bit, but they may not decompensate after cataract surgery. We're just doing it to give them the best possible visual outcome. So if someone's got a good going cataract, mild to moderate Fuchs, probably would benefit from a combined operation, but could probably get away with just doing phaco with soft shell, then you could opt to just do that and then stage the graft at a later date. And there's no harm in doing it that way. It's just nice to try and do it all in one go if you can. And some surgeons like to do it either way. It just depends on personal preference. And the other option is to go private. So at OCL Vision, we have links with America. So we get our tissue pretty much within 1 to 2 weeks. And the other option is some trusts, some NHS trusts now have links with other countries and import agreements. So at Luton and Dunstable, we have an agreement with the USA as well. So we're able to get tissue very quickly if we have to. And the other thing to mention is the eye bank will give you tissue quickly if it's relatively urgent. So it just depends on the urgency of the patient, really.
I think we've got time for a couple more. We've got so many questions. I'm just going to go for a couple more. And Masara, maybe if there are any pressing questions, they can email me and I'll forward them on to you and we'll answer them that way.
Yeah,
MAP finger corneal dystrophy, and they need cataract surgery. How do you plan your surgery pre-op, during the op, and post-op? So what's your thought process?
So you want to assess the ocular surface, corneal topography or tomography, assess for irregular astigmatism, try to determine how much it's impacting their vision. And if you think it is, you can then, I would then do just a superficial keratectomy or epithelial debridement and regularize the surface of the cornea, let it re-heal, and then reassess and remeasure the eye at around 3 months, choose my IOL, and then perform the cataract surgery. So it will be a couple of months wait between both procedures. And post-operatively, you really need to optimize the ocular surface before you consider the cataract surgery. And when you're happy with that, then proceed, and then optimization post-operatively as well. It's really guided by the patient as well, because I've had patients who are so desperate for cataract surgery and just want to get it done that they're not that bothered by the epithelial basement membrane dystrophy. And the majority of patients have it quite mildly, so we might just find it incidentally on examination. The majority of EBMD is not massively visually significant. So I would say the majority of patients we operate on don't have a staged procedure, but you do have to warn them about recurrent corneal erosion, and you do have to counsel them on dry eye management prior to cataract surgery.
And one last one. Do you ever suggest patients have a BlephX treatment or new lids, exfoliation of the eyelid margin before they have cataract surgery? Does the NHS offer that? We
don't actually know. I think it's a personal preference. It has to be done usually in the private sector, usually with opticians, for example. I give them just the standard lid hygiene advice, wipes, cotton buds, that kind of thing. Let them do it themselves at home. If their eyelids are a little bit grotty on the day, or I see them preoperatively and I think this is going to be a little bit dodgy, I will give them chloramphenicol ointment to use as well 1 week preoperatively. And sometimes on the day of surgery, I will actually perform a lid scrub at the pre-op ward round just to get their eyelids really clean before I do the surgery. But yeah, it's not going to do any harm, and it's definitely something that will, in the weeks leading up to surgery, could be very helpful.
I wonder how many ophthalmologists on the pre-ward round go and scrub the eyelids, Masara. You're very meticulous.
They're paranoid. It's very satisfying.
I think we're going to leave it there with the questions. I am going to start a poll, so please don't log off. In fact, let me start this now. And if you could kindly answer the questions. There's only a few questions, I think 3 or 4. It's very helpful. Masara, that was absolutely fantastic. Learned a lot, and hopefully everybody else did too. If anyone does have any pressing questions, I'm sorry there were just so many to get through then, you can email me, purvi@oclvision.com, and I will pass them over to Masara and respond to you as soon as I can. And again, if anyone has any suggestions for future webinars, then please do let me know. It's always good to have you guys come up with ideas, things that you'd like to listen to. Masara, any final words from you before we end the poll?
No, just refer me some patients, please.
I'm sure everybody will do.
I hope it was useful, and yeah, obviously if you have any outstanding questions, please feel free to contact me or Purvi, and I'd be very happy to answer them.
Thank you. Right, for those of you that don't manage to answer the poll, don't worry, your CPD point will still be sent out to you. This is just as one of the regulations that we have to do, and also really useful for us to know whether what we're doing is something that you are all enjoying. So I'm going to end this poll now. And thank you very much. I'm going to say a huge thank you again, Masara. Thanks for sparing your evening and educating us all in such a fantastic way. And for everyone else, have a great evening, and we'll see you soon at some point. Thank you very much. Bye.